following is a conversation with Professor Yan Yiannakou, a consultant gastroenterologist with over 20 years of experience in the field of IBS and treating chronic constipation. Professor Yiannakou is a key opinion leader in the diagnosis and treatment of irritable bowel syndrome, also known as IBS. He has successfully led and completed numerous clinical studies involving different modalities for the treatment of IBS. This was a fascinating deep dive into all aspects associated with IBS. And everyone will get something from this episode, whether you're a patient with IBS, someone that's just generally interested, if you know someone with IBS, or you're interested in the work that we're doing at Enterobiotics. It's well worth a listen. This is Inside Matters. My name is Dr. James McIlroy. I hope you enjoy it. I think a great place to start would be for you to tell the listeners a little bit more about the patients you see.
Yeah, so I see patients with constipation and irritable bowel syndrome. And they are conditions which most people think are just nuisance conditions. But the patients I see have really terrible effects. They're illnesses that affect every aspect of the patient's life. They affect their work. They affect their relationships, their ability to get out, their confidence, their self-confidence, their self-worth. They have really dramatic, severe impact. And this is something that isn't well understood because many patients with mild IBS, and IBS is really common, it's maybe prevalent in 10 to 15% of the population. So lots of people have it in a mild way. But for the 10% of those who have severe IBS, it is life-changing, life-affecting. And that's something that isn't well understood.
When we talk about IBS, irritable bowel syndrome, what are we referring to in terms of the symptoms and diagnosis? And you mentioned that it was some people say it's a nuisance condition. It'd be great to just unpack that a little bit more.
So what is IBS? It used to be called a diagnosis of exclusion, where you've got patients with tummy pain and a change in their bowel habit. They're either got loose frequent stools or hard lumpy stools or infrequent stools. And you do the tests and none of the tests are positive, so you exclude other conditions and you're left with this almost a dustbin diagnosis of IBS. We now recognise that it's not just a dustbin diagnosis, it's a real disease, and it causes abdominal pain and a bowel motion that is uncontrolled, either too loose and frequent or too hard and infrequent. So that's what IBS is. It's also associated with bloating, excess wind, and some people have stomach symptoms, feeling of heaviness in the stomach, feeling of fullness on eating. So those are the main symptoms of IBS, and we now recognise it as a positive diagnosis that we make in clinic when hearing a history that fits that description.
So there's been a bit of an evolution then, which hopefully is still continuing, around this is a real disease. It's not a syndrome as such. There's something real going on here. And is it fair to say that some people may say things like it's just all in the head?
Yeah, that's such a common thing to hear and such a common thing for my patients to hear. And it's interesting you bring up this word syndrome. It seems to suggest that it isn't a real disease because in the past we couldn't find the physiological cause. All the tests were normal. And we should come back to that and talk about how that affects patients having tests that are always normal. But we now understand that there are physiological abnormalities. There is an immune activation in IBS, an immune activation in the gut lining, and that leads to two things. It leads to a change in the microbiome, the bacteria of the gut, which control the bowel motion and the bowel motility. And it also leads to something called visceral hypersensitivity. So let me talk a little bit about that. What happens there is that the immune chemicals that are released, which are ever so slightly just above normal, irritate the nerves and amplify the signals that you're getting. So you're feeling things 7, 8, 9, 10 times more than you would be. So just put that into perspective. Imagine that you're watching the TV and it's a comfortable volume for you and it's volume level 30. Now turn it up to 300 and it's just screaming at you. So yeah, there'll be people with IBS where it's turned up from 30 to 60 and it's discomfort and it's, but it's something you can cope with. But there are people that get cramps from their IBS that are incapacitating, where they can't move. Imagine that happens when you're at work or out shopping. So going back to what we said earlier, it was called a syndrome because we didn't understand, couldn't find the physiological cause. We now can understand the physiological cause. It is a real disease. And in a proportion of patients, it's really severe, or the symptoms are severe.
In the patients who've got severe IBS, could you maybe give the listener a bit of context about how severe it can be? Because some of the listeners might be thinking, oh, God, I've got a bit of IBS as well. It's not that bad.
Well, so if you think about someone with diarrhea predominant IBS, you could be moving your bowels 20 times a day with severe urgency, so you have to rush to the toilet. You might have episodes of incontinence of feces. That alone is going to stop you doing most things that you would want to do. It's going to stop you going out, going to dinner, going to work, going to the gym. If you're the other way and you're constipated, the longer you go without moving your bowels, the more severe your abdominal pain is. You feel bloated, you feel heavy, you feel lethargic. People talk about getting headaches when they're constipated. And it's difficult to understand how that works, but if your liver isn't working in patients with liver failure and it doesn't take out the nitrogen from the bowel motion that's sitting in the gut, that makes you quite unwell. What that shows is that you are absorbing toxins from your bowel. And if you've got a bowel that's absolutely full, there'll be some toxins that are being absorbed that make you feel lethargic, make your skin feel funny. Symptoms we don't really understand, but they're very real. And then there's the pain. The pain alone can stop you in your tracks. It can be sudden and severe and incapacitating, or it can just be chronic and wear you down. So if you've just got chronic pain, how do you feel about going out to dinner or having intimacy with your partner?
Yeah.
It affects all aspects of life.
I mean, it sounds very, very, very tough. Is there any evidence that links, and this is quite a dark thing to say, but is there any evidence that links the severe symptoms with people having depression and maybe even suicidal ideation, that kind of thing?
Suicide and the thought of suicide is more common in patients with severe IBS. What I want to be careful of is, and many patients with IBS are depressed and low because of their symptoms. Psychological illness can affect IBS. Psychosocial illness or challenge can affect how you deal with chronic symptoms in any condition. But what I want to be careful of is the idea that psychology, stress, is the cause of IBS. It can be part of the trigger, but it's not on its own the cause. It's not just in your head.
Mm-hmm. And with regards to what causes it, do we have a sort of set of hypotheses about maybe what the causes of IBS are?
Well, the best way to study that is in patients who have a bad gut infection, a gastroenteritis, because we know that about 10% of patients with a nasty gastroenteritis will end up with IBS. That's called post-infectious IBS. So you can study, say, 100 people with gastroenteritis and look at their gut physiology and biochemistry and histology and psychosocial makeup and various other physiological parameters. And what you see is that the key determinant or the key characteristic of those patients who develop IBS is that the immune system in the gut doesn't settle back to normal, not completely. It's just above the normal level. But it's enough to do what I said earlier, to make those changes to the microbiome to affect the nerves and amplify signals and therefore produce symptoms.
Gotcha. So that's a sort of very elegant example of a defined trigger in the infection.
Yep.
It maybe resolves, but the immune system is still kind of in overdrive a little bit.
Yeah.
Is it just a gastroenteritis, or can it be any infection?
Gastroenteritis is the place we can study it, but what we realise is that there are many patients with IBS whose symptoms start very suddenly, who don't have a history of gastroenteritis. But you can find, if you do full thickness biopsies on the gut, if you take a piece of gut tissue out and study that in a certain way, you'll find evidence that they've had gastroenteritis or another type of infection of some kind, antibodies to certain bacteria, viruses. And the abnormality, we believe, is not the fact that the immune system activates. That's a normal process in this situation. And if we were able to study the immune system over months, we'd probably find it was activating quite regularly. Whenever you eat a new food that you've never come across before, a new chemical, a new environment, been to hospital, going abroad, all these things can probably activate the immune system. Operations certainly do. And one interesting thing to bring up is that a lot of people develop IBS after an operation. And they often feel something went wrong at the operation to cause their IBS. And what's happened is the immune system is activated because of the operation in a normal way. And the thing that hasn't been right is the system for bringing it back down to normal, for settling things down. That's the process that fails. And that fails, who knows, 1 in 1,000 times, 1 in 2,000. And why does it fail? There are some theories about that, but nothing proven yet. And we do know if you are stressed at that time, that reduces the ability of a certain part of the nervous system to respond to that immune activation. It's the nervous system that calms the immune system down. A specific part of the nervous system called the autonomic nervous system, which runs through something called the vagus nerve. That is the main process by which the immune system settles down, and that is what goes wrong, maybe 1 in 1,000, 1 in 2,000 times, to produce IBS. So no, it doesn't have to be a gastroenteritis.
And what's the kind of thinking about how important the microbiome is in all of this?
Well, the microbiome is like an organ. It makes the bowel motion. It drives the bowel to work effectively and efficiently. Without the microbiome, none of that would work. And with a change in the microbiome, you have a change in the consistency of the bowel motion and how fast it travels through the gut. So it is the key to the changes in the bowel habit. It also may have effects on things like pain sensation and other effects on the immune system itself. So the microbiome is central to the health of the gut, the functioning of the gut, and it seems to be a key element that goes wrong in IBS to cause the symptoms.
And I'm going to jump ahead just a little bit, but how many approved products are there that target the microbiome in IBS?
There are none that are prescribable in the NHS.
So there's an unmet need for a microbiome therapy.
There's an unmet need not only for NHS provided treatments, but for any treatment, because the probiotics that are available are only providing one or two types of bacteria.
Yeah.
The microbiome has hundreds of bacteria, and they coexist in an ecological state that is stable. So if you tested your microbiome every week for 6 weeks, it would be similar.
Yeah.
It would be unique to you, and it would be very different from mine, but it would be stable. And it's stable because there is an ecological drive with each of the species fighting for their own space in that niche and also being controlled by the immune system. So the idea that you can change that by adding one strain seems a bit fanciful. Now, it does seem to work for a small proportion of patients. A particular probiotic will help a group of patients with IBS in some way for a period of time. But because it's only one strain, it's not surprising that it doesn't work for a wide variety of patients. And that's why there have been over 100 randomized controlled trials of probiotics, and yet none of them are available for prescription, because these trials show there is a benefit, but not a widespread benefit. So you need something that's going to change the microbiome in a more dramatic way.
Excellent. Well, before we go on to the sort of future and FMT and some of the drugs that we're developing in enterobiotics, I think it would be really helpful just to talk through what exists at the moment as a clinician who's at the forefront of research for your patients. How do you help patients with IBS? What's the sort of flow?
So in medicine, if you want to really affect an illness, if you want to cure an illness, you have to treat the root cause of that illness. So imagine you had a crack in the wall because your foundations were dodgy. If you just fix the crack, it would come back. You need to treat the root cause of the problem to prevent it coming back. And the challenge we have there is that if we accept the root cause as an immune activation, the immune activation is only just above the normal level of the immune system. It's really frustrating because the physiological change is subtle, but the symptoms caused by that change are significant.
Yeah.
Because it's so subtle, suppressing that immune activation is virtually impossible without affecting the normal immune system, and that's not a good idea. So we next go to the next level. If we can't treat the very root cause, what is the next level of affected physiology? Well, there are two elements. One is the visceral hypersensitivity, that amplification of pain signals, and the other is the change in the microbiome. So the pain signal issue is challenging because the way these signals are transmitted from one nerve cell to another is across junctions with certain receptors taking the signal from one nerve to another up to the brain. That gives us an opportunity to determine what those receptors look like, to clone them, and to create treatments that block those receptors and therefore block the passage of pain. And that was where we were at 15 years ago, with a lot of excitement at that time about the possible ability to block these pain signals. Sadly, the drugs that were developed all had terrible side effects. And that has not led to any new treatments. And as far as I know, there is no further development work in that field at the moment. So that leaves us looking at the microbiome. And as we've already said, probiotics haven't been very helpful. They are helpful for some, and I wouldn't say don't use probiotics. I would say try them. But be sure they're helping you if you want to carry on buying them, because you can't get them from the NHS. You have to pay for them yourself. Then there are prebiotics, the food on which good bacteria, so-called good bacteria, benefit from. They can be useful. They can produce short-chain fatty acids and glutamine, which are thought to be helpful. there have been only a very small number of controlled trials of prebiotics, but we're not seeing a great signs of that they're particularly helpful in a wide spectrum of patients. They're helpful in some, just like probiotics. And then we have the whole microbiome treatments, such as fecal transplants. They seem to look good, but that's not a very appealing thing to do. Have fecal fluid put inside of you.
No. Well, indeed, that was the challenge, but also opportunity that I identified many, many years ago.
So I'm really excited by seeing your facility today, James, and seeing how much care is taken in producing this new potential treatment, in making sure it's safe, and seeing the early results from the early trials look so positive.
Yeah, that's great to hear you say that. We have a commitment to quality, and you can feel it.
You can see it.
You can feel it, and you can see it when you go to our offices and labs. Our team is bought in to this is the vision, and they're working really hard to move things forward. And then, of course, the next steps are bigger trials, and we've still got a long road to go. It's a tough journey to develop a new medicine through to approval. But, based on what you said, there really is an unmet medical need.
There really is. And every patient I see requires more treatment than I can offer. And I say to the junior doctors coming to sit in my clinics to learn, I prepare them by saying, we're not going to cure anyone today. We're not even going to give any treatment that really changes their life in a major way. And a lot of what we do in clinic at the moment is helping patients to come to terms with their illness by explaining what the illness is, what it's caused by, that it's not something they're imagining, helping them to understand how they can best cope with their symptoms, come to terms with their symptoms, move past their illness and carry on living. But what is very rare in my clinic is giving a treatment and having a patient come back and say, thanks, doc, that's changed my life. That's very rare.
There's still a lot of work to be done.
A lot of work to be done.
And something you mentioned to me earlier, which I think is worth highlighting, was around, it seems like patients are very astute in IBS, and they've read about the causes, and I think it was something you said earlier about how they're more keen to try something that's microbiome in nature. So is it fair to say that there's both an unmet medical need, but there's also patient demand for therapies like the ones that the company's developing?
There's a huge demand. There's a real desire for something that A, is effective, B, is efficient in that ideally you just take some tablets.
Yeah.
And something that also validates the fact that these individuals are suffering. The fact that we can't offer them any treatment seems to be a slap in the face in a way, because we say the tests are normal. Sometimes that can be very harmful. You've got terrible symptoms, you go to the doctor, you explain, the doctor does the tests, and all you get back is, don't worry, the tests are normal. And that makes you feel unvalued, unvalidated. So providing an explanation helps that, an explanation of why the tests are normal, that there is an abnormality there, but it's just not visible on the tests that we do in clinical practice. And then providing a treatment also is a form of validation. But obviously the main reason for providing the treatment is to remove these terrible symptoms.
Yeah. Do you think it's maybe we just don't understand yet enough to be able to develop a test or something which is more binary? Like, are there other precedents in medicine where we haven't understood something, so we've said it's just stress?
Well, that's a really interesting question, because if you look at the history of medicine, all sorts of illnesses that we now recognize as physical diseases were considered to be stress-related. So diabetes, thyroid disease, multiple sclerosis, tuberculosis, peptic ulcers, ulcers of the stomach. When I was at medical school in the 1980s, I remember seeing a patient with a peptic ulcer, and he was quizzed about the stress in his life, and because his work was stressful, he was advised to go part-time because stress caused ulcers.
Wow.
And if you look at research on peptic ulcers between 1960 and 1980, a lot of it was around stress factors and psychological factors. In 1990, the treatment for peptic ulcer to cure a bacterium, Helicobacter, with a 2-week course of antibiotics was published. And since then, we've had no further publications about stress and peptic ulcers. It's interesting that if you look back in history, even patients with chronic cough in the 1930s were sent to mental institutions. And that was chronic cough due to tuberculosis. And they knew in those days that it was an infective process, but they just had no treatment. And until doctors have a treatment for a condition, there is this tendency to almost blame it on the patient, to say it's to do with your stress. That, of course, is a vicious cycle, because you're feeling real symptoms, you're suffering, you're told it's all in your head, there's nothing we can do. That makes you depressed and anxious and stressed, and it's self-fulfilling. You get stressed.
And in your kind of clinical practice toolkit at the moment, what are you doing for your patients? Because there are some drugs in the US which are kind of used, like linaclotide, for example, and rifaximin, tenanopor. Given that these drugs are selling so well, I guess there's an assumption that they're highly efficacious. Would that be the wrong assumption?
Well, we have 2 of the 3 that you mentioned available to us in the UK, but they are disappointing, and they're disappointing because we started to talk about a hierarchy of treatment depending on whether you're dealing with the root cause, the second level, which was the microbiome and the pain amplification, or just the symptom, not dealing with any disease process, but dealing with the symptom. So linaclotide is a drug for constipation predominant IBS. It doesn't alter anything about the physiology of IBS in the body. It's purely a strong laxative. It's derived from the E. coli toxin, which typically gives you diarrhea. It's a very strong laxative. And if you're very constipated, it can be really helpful. But not without, it doesn't take you to a normal state. It just takes you to a loose, urgent state.
That's interesting.
And many of my patients with constipation struggle with fecal incontinence because the laxatives they take have to be so strong that it causes them diarrhea and urgency. We did an audit of 1,000 consecutive patients referred to my clinic some years ago. On average, they had 16 years of history of constipation and over 10 years of constant laxative use. So treating the symptom without treating the disease process is unlikely to give you good results. And that's where we are. We're just treating symptoms.
So these patients who've been on laxatives for well over a decade, are they taking the laxatives just to kind of get some relief rather than altering the course of their disease? To go back to the cracks in the wall analogy, is that what's happening there?
Yeah, exactly. You are just papering over the cracks. Yeah. You are treating the constipation without treating the underlying cause of the constipation. So nothing ever gets better.
Yeah.
That isn't to say they shouldn't use laxatives. I think that's a really important message.
Yeah.
Because laxatives themselves, it's interesting, we talk about medical history and medical prejudices. Laxatives developed a bad name for themselves in the 1950s and 60s. There was some not very good research that suggested that laxatives caused damage to the nerves of the gut. And in some people, laxatives were overused as part of anorexia-type syndromes. And third factor there is that laxatives are often generic treatments not produced by any one pharmaceutical company. And therefore, if a newspaper or a journal article produced some negative statement about them, there was no advocacy.
Okay.
So put all that together and you end up with a myth that laxatives are bad for you, that laxatives damage your bowel. That has now been disproved. Laxatives don't damage your bowel. And if you have constipation and you need laxatives, then it's important you take them and you don't feel guilty about it. You're not damaging yourself. What I am saying is that laxatives are part of the treatment for IBS-C, but they're treating a symptom and they're not likely to create a change in the outcome of the illness.
Makes sense. So what do you do then if someone's if they've still got abdominal pain when they're taking laxatives?
What we can offer, the only thing we can offer really is a drug called amitriptyline, which used to be used 20 years ago as an antidepressant. But at a tenth of the antidepressant dose, it does seem to modulate, does seem to affect some of that pain amplification. And I guess it would reduce pain by between 30 and 50% in a lot of patients, but it does that ever so slowly over a 3-month period. And one of the problems with amitriptyline is continuing to believe in it and take it when you don't feel that you're getting any better. But it also has it improves your sleep, but in a good proportion of people, I would say up to 20%, it leaves you feeling drowsy in the morning. And some people just can't manage.
And has there been a lot of drug development effort over the last 10, 15 years? You mentioned some of the pain modulators. Has there been It's been really disappointing. There's a new treatment for diarrhea, predominant IBS, called Enteros gel that works well. But no major breakthroughs. The amitriptyline, use of amitriptyline has been proven in a large clinical trial, but we've been using that for many years. So we really need the pharmaceutical industry to get interested in IBS and start developing new treatments. And why do you think there's not, in recent years, been a big amount of pharmaceutical company interest based on the interactions that you have with them?
Well, one of the good things about IBS is no one dies from it. But that also is a challenge because it isn't considered to be a dangerous illness.
Yes.
There is actually a significant suicide rate in patients with IBS, severe IBS, but in general it isn't considered to be a severe illness. And also, it's such a common condition, with 80% of patients having relatively mild or tolerable symptoms, it becomes known as just a nuisance.
Yeah.
And that's really sad for the 10 or 20% of patients who have severe symptoms, whose life is severely affected. But when they try and tell their neighbour or their boss or their work colleague that they're suffering, they get very little empathy because their boss or their work colleague probably knows someone else who has mild IBS and it's just a nuisance condition. So it's a double whammy. You end up with a condition that gives you lots of symptoms but doesn't have a reputation for being serious or dangerous. Now, transpose that into what the regulators look for to approve a new drug. They need to be sure that it's going to be effective in terms of saving lives or improving health in a measurable way, and also be confident that it's not going to bankrupt the NHS. And something that is so common as IBS is difficult to approve. a new drug for IBS when up to 10, 15% of the population might then ask for it. Gotcha. So the fact that it's common makes it difficult to get new drugs approved. And I think the pharmaceutical industry can see that. They see the challenge, whereas approving a drug that improves the mortality of a cancer treatment, that isn't a challenge. That's a small group of patients, a very defined group, with very defined benefits.
Yeah, it almost fits better in the kind of social healthcare system that we have, where these calculations are based on, how many quality adjusted life years.
Yeah.
So if you were to kind of look into the future then, what would be your desire and your dream? How will the field develop? What are you hoping to see?
Well, I think we always feel that prevention is better than cure. And one day in the future, I think we'll understand the cause of the failed suppression of the immune system that happens and find a way of preventing that from happening. But I think that's decades away. In the meantime, I don't expect any new treatments based on modulating the immune system. And I think the work on pain receptors has gone as far as it can. So what I hope to see in the next 10 years is better treatments for improving the microbiome, which is that next level that we need to focus on in order to get an improvement of the disease process, not just the symptoms.
Mm-hmm. And do you think we'll ever get to a point where maybe patients don't need laxatives anymore? Some of their earlier dietary advice, peppermint oil, these kinds of things, they'll go just because we understand it? Or do you think it's going to be this continuum? And
I'm not sure we're going to find a magic bullet that means we only need one treatment.
Yeah.
I think it's a complex illness with multifactorial processes, and that needs multifaceted treatment. But we need something more effective than what we currently have.
And without divulging any of the specifics, because we're presenting the data in about a week and a bit at DDW, but what's excited you about some of the information you've seen from our studies?
I think there's a clear separation so these are placebo-controlled trials, very robustly conducted trials, where no one knows who's on active treatment and on placebo. And there's a clear separation for almost all outcome measures between the active treatment group that have got better quickly. And I think that's important. So after the first dose, you're seeing a rapid resolution of symptoms, with improvements in different areas, not just pain, not just frequency of bowel motion, but in all areas of symptoms, bloating, pain, bowel movements, and the overall validated questionnaires that we use to assess severity of IBS seem to be showing an improvement in scores that are not only statistically significant, but seem to be clinically valuable benefits, meaningful benefits. And that's what's really quite exciting.
Yeah.
Obviously, those benefits need to be proved in larger trials.
Absolutely.
We're still talking about relatively early phase trials, and we're still talking about results that are fairly short term. So the trials will need to get bigger with longer term outcomes. But the other thing is interesting, if I'm allowed to talk about it, is the data we saw today about the fact that the bacteria from the provided treatment are settling down and being maintained in the gut bacteria several weeks after the treatment's been given.
Yeah.
So they are making a real impact, changing the microbiome.
Super exciting to see that. Yeah, very, very exciting to see that a substantial number of microorganisms in the capsule are finding a home.
Yeah.
And that is super cool. What we've not spoken about, which may be of interest to some of the listeners, is some of the registries that you're involved in.
Yeah, so one of the hardest things, James, about research is getting people to be recruited into clinical trials. That's because clinical trials, well, some people are fearful of clinical trials. They still think that clinical trials involve being a guinea pig for dangerous experiments. And the first thing to say about clinical trials is that they're really safe. They're really well controlled, and the point at which late phase clinical trials are being done, the safety assessments have already been made, and these are generally very safe things to be involved with. And then access to trials is affected because typically patients get involved in trials when they come to the clinic of a doctor who is recruiting to a trial. So you have to be at the right clinic at the right time when that particular doctor is there, not on holiday, and conducting a clinical trial. So we're trying to improve this and give people access to trials. And so if people want to register for trials in irritable bowel syndrome, they can register at contactmeibs.co.uk. And if you just put that into Google, Contact Me IBS, you'll get the website, 5 minutes to register, and we'll let you know of any trials that are going on in IBS that you might want to be involved with. And there's no obligation. This is an NHS registry. It's very secure. We won't use your data for anything else. But when the trials come up, we'll let you know that they're available and see if you're interested.
So we've been speaking for a little while now. It'd be good to move the conversation to a bit of a wrap up. Would you be able to share any insights into what you're most excited about in terms of developments? You've talked about your registry, some of the trials.
Yeah, so there's lots of developments in the way we run clinical trials. There's registries. There's the fact that we can run clinical trials virtually in some cases. These are called decentralized trials, though I think that's a terrible name. It means you can be at home and have all the trial assessments done remotely. And there's developments in running trials through NHS research centres that are more efficient and effective. So there's the trial side of things. And in the terms of treatments, I'd like to see more than what we're seeing, but certainly very excited about the work that you're doing, James, with the microbiome work.
Thank you. Well, I think that's really an awesome note to finish on. So if the listeners want to follow you or your research, where can they find you?
Yeah, I'm keeping my head down, James.
Old school.
Because I am on a retirement pathway. And there aren't many gastroenterologists with a specific interest. So forgive me if I don't hand out an email address.
Fair enough. No, that's fair enough. But wanted to thank you for coming here and for your participation. I've had an amazing day. Really enjoyed the lunch and your talk earlier at our company. So thank you.
Thank you.
Thank you very much.